We're going to talk about menopause. So, menopause is something that every female is going to go through, and it's a significant transition where women will have a noticeable change in their health, their mood, and potentially their overall quality of life. When does this start? So, typically, the average age is about 51. And perimenopause is the time around menopause, which is around about 4 years before. So typically that 4 to 10 year window around menopause is perimenopause. And then prior to that is what's called premenopause. And after that is called postmenopause. So how do you know you've gone through menopause? So menopause is essentially 12 months after you've stopped having menses or having a period. But there's sort of a whole host of symptoms that occur prior to then around perimenopause. And so the early stage of perimenopause occurs when your periods are delayed for more than 7 days than they used to be. So there's some irregularity. And then late early perimenopause is when the delay is more than 30 days. But the interesting thing to know is that vasomotor symptoms, or what we commonly call hot flashes, start even before you go through menopause. So you can see them and they will continue for up to a decade for some people. There's a whole host of other symptoms that women can experience during menopause, and this can include those vasomotor symptoms we talked about, like hot flashes or night sweats. You can see genitourinary symptoms like irritation, dryness, or pain with sex, sleep disturbances, and even mood disturbances. And I think even as equally important, you may see change in your bone loss as well as in your lipid profile. And so when you think about the symptoms of menopause, they occur because estrogen receptors are all over the body, including the brain. So sometimes people can have inability to concentrate, poor memory, they can have mood swings, they may notice some changes in their skin because estrogen receptors on the skin causing decreased collagen and, even crepey skin. You can see joint pain or even frozen shoulder. You can see changes, of course, as we mentioned, in the vagina, but also urinary symptoms. So more urgency, gotta go, maybe even having leakage or recurrent urinary tract infections. So when you think about what happens is you go from having a relatively normal amount of estrogen to going very low in terms of estrogen levels. So in the beginning phases, you will have some short-term symptoms, and this will include the hot flashes, the sleep disturbances, and the mood issues, which typically tend to get better with time. However, those urogenital symptoms like having vaginal dryness or urinary incontinence or overactive bladder, those tend to last and may even progress with time. The other big change that happens is your bones get weaker. So you get osteoporosis. And that is, again, another long-term consequence of having estrogen loss. So let's talk about hot flashes. Hot flashes will occur in up to 80% of women. And it's basically a sudden sensation of heat that you feel maybe on the upper chest or the face that rapidly becomes generalized, meaning you feel it all over. It typically lasts for about 2 to 4 minutes. You can sometimes have palpitations with it or anxiety. And sometimes you may not even have the heat sensation, but you may just notice that you're feeling very irritable, but it goes away. And this occurs periodically, repeatedly over the course of the day. You'll also see that because of these hot flashes, you may see problems with sleep, with concentration, with mood, with energy, and sexual activity. Now, other symptoms I've sort of alluded to already, but brain fog and change of memory is very often seen. The genitourinary syndrome of menopause, which includes things like vaginal dryness, discomfort with sex, urinary urgency, urinary frequency, urinary incontinence, and recurrent urinary tract infections are all symptoms of the genitourinary syndrome of menopause. Now, as I mentioned, there are long-term consequences, including bone loss, cardiovascular changes, skin changes, and even balance has been seen as a concern with these hormonal changes. When should you get treated for menopausal symptoms? So typically, very strictly, it is indicated for vasomotor symptoms like hot flashes and for the prevention of osteoporosis. But I would argue that if you're having other symptoms like sleep disturbances, mood disturbances, joint problems, or you're having concerns about the risks of cardiovascular disease, dementia, diabetes, or obesity that are correlated with having low levels of estrogen, that's an indicator to at least discuss it with your doctor. Now, when should you avoid treatment with traditional hormones. So if you have a history of breast cancer, and again, this is relative, and we'll discuss this a little more in detail. If you have congestive heart failure, if you have previous strokes or blood clots, this is typically for oral treatment options. If you have active liver disease, unexplained vaginal bleeding, or high-risk endometrial carcinoma, then doing any sort of hormonal option is not recommended. Now, you may have heard of a lot of sort of things that people tout on the internet of being effective, but based on randomized controlled trials and very rigorously studied clinical data, many of these things have been deemed not effective. So things like acupuncture, evening primrose oil, flaxseed exercise. Unfortunately, you can't exercise your way out of menopause. Ginseng, dong quai, wild lamb, progesterone creams, which are ubiquitously prescribed or given to women, they actually are not effective. Chinese herbs, reflexology, or magnetic devices are not going to fix the hormonal abnormalities that are associated with menopause. And this is a list, and this is just to show you the wide variety of options that we have available to you for menopausal hormonal replacement therapy. And this is really just to show you that we can find something that works for you as an individual if you're suffering from menopause. There's a whole host of options, and you don't have to settle for just one standard treatment option, particularly if you're having side effects or you're not feeling good on that particular option. So let's go over, in terms of estrogen, what are the options? Estrogen is predominantly the main hormone that is causing a lot of the consequences associated with these hot flashes, with the symptoms of brain fog, of musculoskeletal joint conditions, and a whole host of things. So there's transdermal options, which are gels and sprays, and these are essentially nice and often used because they have a lower risk of blood clot or stroke. In fact, probably unlikely to get one. So if you've had a history of these things, transdermal options are usually a good option for you. Now, absorption of any transdermal product is variable. So some people will need more and some people will need less, and some people may not absorb it as well as others, in which case you may consider other options. So another option is oral. And oral is not a bad option, although there are some other risks with it. So the advantages are you see an improvement in some of your lipid parameters. So it actually improves your HDL, which is the good cholesterol, and decreases your LDL. However, it can affect your cortisol, your sex hormone binding globulin, which can affect your levels of testosterone and maybe affect libido, although we haven't seen that. And it may cause problems with your thyroid binding globulin. If you're already having thyroid issues, it may not be the best option for you. There are some contraindications, generally speaking, with oral. So if you have high triglycerides, if you have gallbladder disease, if you have a known clotting disorder like factor V Leiden, or a personal history of venous thromboembolism. Now, there are depot injections which are available. They're not used quite as often. And there's also vaginal rings, which are systemic dosing or high dosing. So they're placed in the vagina about every 3 months, and they release slow release estrogen over the course of those months. And so the advantages are that you don't have to think about it too often, and it's there. However, the disadvantage is something that is placed in the vagina. Now, the one thing I want you to realize is bioidentical means that estrogen is plant-based, meaning that it's not made synthetically. It does not mean that it has to be compounded, which is what a lot of people tend to market as we offer bioidentical hormones, meaning they're compounded from a pharmacy. Now, compounding is not a bad thing inherently, but ideally we recommend using FDA-approved estradiols or 17-beta estradiol, which is available at your regular pharmacy via prescription and is also bioidentical. Now, side effects most commonly are things like breast tenderness, and oftentimes that first 6 months while you're figuring out your dosing, you may see some vaginal bleeding, and that's okay and not unexpected. If it persists after 6 months, then we need to evaluate further. In terms of risks and benefits of menopausal hormonal therapy, I wanted to touch on this because I think a lot of people have heard a lot of misinformation, and the Women's Health Initiative was sort of this large study that sort of changed the way people prescribed estrogen and progesterone for women during menopause. And this was because they found some risks. Now, the important thing to realize is that this study looked at types of medications, the types of estrogen and progesterone that we don't really use. It used something called conjugated equine estrogen, which is from a horse, and also a synthetic progesterone called MPA. Also, it was not used on people who were necessarily symptomatic and needed the therapy. It was just used on a whole host of women who tended to be a little bit older and have a whole host of other sort of comorbidities. But what they found was that when you had estrogen and progestin together, they saw a higher risk of coronary artery disease, so about 2.5 cases out of 1,000. They saw 3 additional breast cancer cases out of 1,000, about 2.5 additional strokes out of 1,000, and 3 additional blood clots in the lung out of 1,000. But they saw a lot of benefits, and that was fewer colorectal cancer cases, fewer endometrial cancers, fewer hip fractures, and most importantly, a reduction in all-cause mortality. And when they looked at estrogen alone, they actually saw no risk of increase in breast cancer. They saw an improvement in cardiovascular heart disease. They saw an improvement in invasive breast cancer and stroke and colorectal cancer and all-cause mortality. And so the question then is it the progesterone that's causing it? Well, we don't really use MPA anymore. And so is this still relevant? If you have a uterus, then in order to protect your uterus from developing an endometrial carcinoma, you need to use progesterone with the estrogen to prevent the uterine lining from building up and then putting you at risk for developing a cancer. If you don't have a uterus, then estrogen alone is just fine. You don't need a progesterone. However, there are benefits. Some people derive benefits with sleep as well as mood with the progesterone as well. So what are the options for progesterone? So the one that's most favored is micronized progesterone. It's a very small dose. It's bioidentical, and it does not appear to increase the risk of breast cancer or cardiovascular disease like MPA. However, some people do have difficulties tolerating progesterones because they get some bloating and they get sort of tearful or mood changes. And so that is sort of the disadvantage of any progesterone option. And you could take it daily, or if you are on perimenopausal and still bleeding, you can take it about 12 to 14 days a month around the time you're having your period, so the bleeding will coincide. There's also the MPA, which is well studied. However, it does have these increased risks that I showed you and does tend to have an unfavorable effect on your lipids. Also, if you have an IUD, that will work also to specifically a leave-on or gestrol or progesterone containing IUD will also help with preventing this risk of a uterine lining buildup. The good part about this is it has lower systemic concentrations. It mostly focuses its effect on the uterus. So if you're having difficulty with side effects related to progesterone, then this may be a good option for you. The disadvantages is this minor procedure to get an IUD placed. There are some alternative options as well. So there's Duo-V is the brand name. It's called basidoxifene and conjugated estrogen. And this avoids progesterone, but still allows you to get the benefits of preventing uterine lining buildup. And so it is an option. It does use conjugated estrogen, which is not bad, but it's certainly not considered bioidentical. It's good for people who develop sort of breast tenderness with estrogen or have difficulty tolerating progesterone. There's also combination therapies. So if you don't want to take 2 separate things, you can get estrogen and progesterone combined in either oral or transdermal preparations. It can also use transdermal testosterone. Now, its benefit is primarily noted in the libido area, but there's also some benefits for bone health and other issues, other things. So maybe something to consider if you are struggling with sexual dysfunction. There's also Tibolone, which I won't spend too much time on because it's not available in the United States. It is available in Europe. Essentially, it's a synthetic steroid where the metabolites of it have both estrogen, androgenic, and progesterogenic properties. There's also options that if you don't want to take any hormones at all, or you can't take hormones, and that can be using SSRIs or SNRIs, which are essentially antidepressants. The most studied one is venlafaxine in terms of improving hot flashes. There's another medication called fezolinetant, also brand name is Veozah, and that works on the brain receptors that cause hot flashes, and so that can be helpful. Gabapentin can also be used. And then there are some promising therapies which are not fully proven in evidence, but may have some benefit, including cognitive behavioral therapy, hypnosis, and other mind-body therapies like mindfulness, and something called a stellate ganglion block, which you need to be referred to a specialist for, which can sometimes help as well.